Good evening, everyone. How are you all? All right, so let's start our tonight's session. Obviously, it's a little tiring for many of you to get these back-to-back classes. But as we said yesterday, that these are the sessions which will make your preparation better. So obviously, this stress comes with some good memories and also some good experience. So tonight, mainly we are focusing on cardiology session 2. And that means that we are trying to finish cardiology tonight. So we had our first class on cardiology, and we mainly started with the syncope cluster. I hope that many of you have already done that class, because that class we discussed about the approach, we discussed how to take a history, physical examination. So those part we already have done. So we will just move forward rather than just going through the approach tonight. Okay. So our first cluster for cardiology session 2 is palpitation or nervousness cluster. Palpitation or nervousness cluster, it is very important for your exam. Especially palpitation comes in many ways. And sometimes in the exam question, you might just get that patient coming to you with feeling nervousness. And nervousness has a lot of causes. So a patient can feel nervous for a multiple number of causes. But you can always remember this palpitation differential diagnosis when you are asking questions about nervousness. So what are the differential diagnoses of palpitation? So we have CVS causes, CNS causes, endocrine causes. Then we have 2A, which is anemia and anxiety related or psychiatric. Then menopause can be one of the important DD. Some recreational drugs or excess tea, coffee, and some of the medication. So we can remember by 2C, 2M, 2A, and 2E. And you can remember by MACE. So MACE is actually the mnemonic for your nervousness cluster. Okay, so 2M, 2A, 2C, and 2E. So in case of C, we have CVS and CNS causes. For CVS causes, it can be ischemic heart disease. It can be myocardial infarction. Then hypertension. Arrhythmia is your main differential diagnosis, and sometimes some valvular heart disease. In case of CNS, same differential, so a stroke or TIA, epilepsy, infection, head injury. Then come to 2M. In the 2M, we have menopause and medication. In 2A, we have anemia and anxiety. And in 2E, we have endocrine and excess tea, coffee, recreational drugs. In the endocrine causes, thyroid disorder can make you nervous or also having a palpitation. So hyperthyroidism, hypoglycemia, and pheochromocytoma. So these are the endocrine causes of palpitation. So if you just remember MACE and just remember in your head that 2M, 2A, 2C, 2E, you can easily remember these differential diagnoses in your exam. So that's your DD for palpitation. Now come to the history taking. If a patient comes to you with palpitation, which is started maybe 2 hours ago, let's say acute condition. So you have to make sure that patient is hemodynamically stable. So just like before, our initial approach will be same. So if this is a face-to-face exam, then we would start like, hi, John, this is Dr. Harshan, one of the doctor here. I got to know from the notes that you are having racing of your heart for the last 2 hours. I'm very sorry to hear that, but now that you are here, we will take care of you and we will try our best. We will try our best to manage your symptoms. Now, before I ask you any more questions, I would like to make sure that you are vitally stable. So please excuse me for a moment. I will talk to my examiner and come back to you. So dear examiner, is my patient vitally stable for further history? An examiner says, stick to your task. You just say to the examiner, thank you, examiner. You go back to the patient and say, thank you so much for waiting, John. Now, would you please tell me a little bit more about your racing of the heart? So that's the open-ended question. Patient will give you some information like, yes, doctor, I was just walking along the road and suddenly it started. I can still feel my heart is beating. So then you can start asking that, is it for the first time that it happened? Did it start suddenly or gradually? If patient said, no, doctor, it is not the first time, then you have to find out the details of previous episodes also. So if patient said, no, doctor, it's not the first time, you have to ask that, so how many episodes so far? And what exactly were you doing in those episodes? Then you need to find out how long each of the episode persists. Is there anything which can make it better? Anything makes it worse? And is it a continuous palpitation or on and off? So these are your HOPC, which is your history of presenting complaint. So patient came to you with feeling racing of heart or racing heart. So in that case, you have to ask these questions. A lot of time I have seen candidate ask the role player that, do you know that, does it sound like, or does it sound like? So what actually candidate do, they tap over the table and they actually try to find out that if it is a regular heart rate or an irregular heart rate. Now, I don't feel that it is very important. So please don't do this kind of tapping over the table. It's not needed because you can easily check the pulse of a patient rather than asking this kind of question. Okay, so forget about this tapping over the table. All right, so this is your palpitation detailed question, and then you move to your associated symptom. So along with the racing of heart, any other symptoms do you have? Like, do you feel dizzy or lightheadedness, which is very common with palpitation? Any chest pain, any difficulty breathing, any nausea, vomiting, excessive sweating? Why we are asking this question? Because you are actually ruling out CVS related differential. So if you're asking about chest pain, difficulty breathing, you're asking about nausea, vomiting, excessive sweating, that's actually your ischemic heart disease or MI differential. Any headache, any problem with your vision or speech, any weakness or any loss of consciousness. That's your CNS differential. Okay, so you are already asking the differential diagnosis when you are asking the associated symptom. Once you have done CVS CNS, what's your next? Your next is endocrine. So ask the endocrine DD. So for hyperthyroidism, have you noticed any change in your recent weather preference? If patients say yes, you need to find out that what is the weather preference do you have? Like which weather do you prefer? Patient with hyperthyroidism, they will feel better in a cold weather. They can't tolerate heat. Okay, so in that case, they will say, yes, doctor, I can't tolerate much of the heat. I like cold weather. So that's one of the clue that this patient might have a thyroid problem. Then you can ask that, have you noticed any change in your bowel habit? Any change in your body weight? Hyperthyroidism patient will have diarrhea and they will also lose weight. Then move on to the next differential, which is your pheochromocytoma. Pheochromocytoma patient usually presents with a paroxysmal attack of headache, sweating, flushing of the face, and sometimes they also get this episodic hypertension. So only question that you can ask that, have you noticed any time that you get intermittent headache, sweating, flushing of your face? For hypoglycemia, did you skip your meal today or do you have diabetes? Then we have anemia. So how is you can ask the patient that, do you feel tired these days? If yes, then you can ask that, what is your typical daily diet? Are you a vegetarian? So those kind of questions you can ask. Then for infection, you can ask about any fever, cough, any runny nose, because sometimes if a patient has got a flu-like illness, like a high fever, that can also give palpitation. So ask the patient that, are you feeling fine now? Any fever or any flu-like illness? Then for electrolyte imbalance, any vomiting or any diarrhea, then go to the SADMA. So do you smoke or drink alcohol, any recreational drugs, any excess tea, coffee, or any other drugs? Ask about their medication history, that are you on any regular medication? Ask about their past medical history, like any diabetes, high blood pressure, heart condition. Very important to ask about family history of sudden cardiac death. And because stress or anxiety is one of our DD, give some confidentiality in here. Say that, John, I'm going to ask you some personal question about your home and your work. I want you to know that these are confidential between you and me. So who do you live with at home? Is there any stress at your home? Do you do any work? Is there any stress at your work? To rule out generalized anxiety disorder, we ask a questions. We ask the patient that, do you worry a lot about most of the trivial things? Or are you an anxious personality? So patient with generalized anxiety disorder, they worry about everything. So anything happens around them, they are always anxious. So ask the patient that, do you worry a lot about most of the trivial things? If a patient is female patient and around the age of 40 or 50, then you have to also make sure you rule out the possible menopause. So ask the patient that, when was your last menstrual period? Okay, ask about, is it a regular or irregular or not? If you find out that patient's period is irregular, then try to rule out possible perimenopausal symptom. What are the menopausal symptoms? So we can ask the patient that, any hot flushes, any night sweat, any frequent mood swing, any dryness in your down below. So those are your usual menopausal symptoms. So especially if a patient is above 40 and female and their period is getting irregular, then you can ask the patient about these menopausal symptoms. There is a question which comes in exam about perimenopausal stage causing the palpitation. Okay. So that's actually all of the differential diagnosis and the history format for palpitation. So to give you the summary, you will start with hemodynamic stability, and then you will start the palpitation question, then associated symptom, or you can say your CVS and CNS differential, followed by endocrine, anemia, anxiety, electrolyte imbalance, infection, and lastly finish with SADMA, past medical history, family history, and social history. If it is a female, then obviously we will also rule out menopausal symptom. Any question, guys, so far? All good. So that should be fine then. So let's move on to physical examination from examiner. Any possibility of PE? Yes, there is a possibility of pulmonary embolism, but again, you are asking the questions of pulmonary embolism by asking chest pain, difficulty of breathing. So obviously, if it is a PE, you will get some of the other feature also, not just palpitation. Now, when you come to physical examination, this is a face-to-face scenario. So you will ask to the examiner that, dear examiner, I would like to do physical examination on my patient, starting with the general appearance. Is he comfortable or in distress? Then we will obviously ask about the pickled, which we have already done in our last class. So ask about any pallor, any cyanosis, any clubbing, any sign of dehydration. Ask about vitals and BMI. Same thing, exactly the same physical examination that we have done in syncope cluster. It is totally same in here also. So neck, then you have to do the CVS, CNS, and other system. Don't forget in the office test, you have to do the ECG as well. All right, so that's your physical examination from examiner. Because we have already discussed it in detail in the last class, so we are just skipping this one because it's just same thing. Moving on to the cases. The first case is supraventricular tachycardia. So you are a junior HMO in ED. A man came in with thumping or racing heart and giddiness started today. So giddiness, dizziness, lightheadedness, everything are same. So your task is to take a history, physical examination from examiner, ask investigation from examiner, explain diagnosis to the patient. So the positive points in this case would be that patient started to have palpitation and lightheadedness since 2 hours, also getting a little bit of shortness of breath. Previous 3 episodes started suddenly, lasted 2 hours, and then stopped all on a sudden. Take 6 to 8 cups of coffee a day. So that's one of the findings you can get in your exam very commonly. And it is also very commonly missed question because normally you feel like you ask all the important things, but you just forget about tea, coffee. But that might be the only positive finding in the exam. So no smoking or alcohol history, no other recreational drugs, no family history of heart condition. Patient is also quite anxious personality, and they can also give you some stress in the history. So in one patient, there can be multiple kind of reason that why patient gets palpitation. But obviously, if this is related to stress or anxiety, the ECG finding should not be like a supraventricular tachycardia or AF. Okay, so that's how you differentiate that. It's not just anxiety, the heart itself might have some problem. If you get in the ECG, either a AF or SVT or any of the arrhythmic features. Now, your history is done. You will use the same history format. Then you come to the physical examination. You finish that. Your third task is to ask investigation from examiner. That is the ECG. When you ask ECG from examiner, examiner gives you this on the screen, or examiner gives you to your hand. So your task in this case would be ask investigation from examiner and explain investigation to the examiner. That means you have to also explain the ECG to the examiner. So this is the tricky part. And a lot of candidates, they don't know how to explain the ECG as a format. So first of all, when you get a patient who has palpitation, what is the most important thing you look at? You look at the long lead, because long lead usually gives you the arrhythmia. You don't need to look at the chest lead, initially at least. But you can have a look later on, but a patient who is having palpitation, most likely they have some arrhythmic problem, and you will get some finding in the lead 2 or the long lead. So always start with the long lead first. To give you a good idea about ECG, all of you might already know that in a ECG, you have some limb lead and chest lead. V1 to V6 are your chest lead, and lead 1, lead 2, lead 3, AVR, AVL, AVF, these are your limb leads. Lead 2 usually is the long lead that is usually given to show you the arrhythmia. Now, if you look at this ECG in the lead 2, you can see that patient, obviously, the heart rate is very high. How we know? When you look at a ECG, first thing that you look that what is the rate and rhythm. How we measure the rate? A rate usually measured by, this is your one of the largest square. In one large square, there are 5 small square, as you can see. Okay. Now, this is your R wave. This is your R wave. So you have to find out that how many large square in between 2 RR interval. So this is 1 R, this is 1 R, right? So in between this RR interval, how many large square are there? So in here, you can see the largest square, maybe just one largest square divided by 300. Sorry, it should be not like that. So in this case, 300 by 1. Okay. So this is the heart rate is 300. If you get 2 large square in between 2 RR interval, then 300 by 2, which becomes 150. And then if there is 3 large square, then 300 by 3, which is 100. If there are 4 large square, then 300 by 4 equal to 75. So you don't need to look or calculate that. You just remember this, that if there is 1 large square in between 2 RR interval, heart rate is most likely 3. If 1, then 300. If 2, then 150. If 3, then 100. If 4, then 75. In your head, you just remember this, okay? Because you don't have that much time in the exam to calculate the heart rate. And you don't need to be very exact. If you say the approximate heart rate in the exam, that's more than enough. Okay? So you know the heart rate is high. After that, you check the rhythm. Rhythm means if all the RR interval is having an equal space. Obviously, this RR interval has 1 large square, this one has 1 large, this one 1 large. That means the rhythm is regular in this patient. So now we know the rate and rhythm. After that, you remember what we talked about the usual ECG. So normal ECG has P wave followed by QRS complex, and then there is a T wave. So this is your P wave. Then we have got this QRS complex, and that's the T wave. So then you have to explain how is the P wave complex, what about the ST segment, and what is the T wave, and what about the QT interval. So in this ECG, if you look carefully, you can see that this patient actually does not have any P wave. Okay, what you see here, that's the T wave. Because the wave that follows QRS complex, that is the T wave. So because this wave is coming next to QRS complex, so this is T wave, not P wave. Okay, so this patient does not have any P wave. So you have to say absent P wave. Then you go to the QRS complex. Obviously, QRS complex is narrow in here. A normal QRS complex is 1 to 3 small square. Okay, in this patient, it's not even 1. So that's a narrow QRS complex. Then you go to the ST segment. So that's your ST segment. And ST segment in here, it's normal. There is no ST elevation. How we know if it is ST elevation or not? You look at the baseline. So this is the baseline, right? And you can't see that no ST wave is coming here. So ST wave, it's in the baseline that you can see. And obviously the T wave is normal in size and shape. And then you have to comment on the QT interval. QT interval is start from here. That means you start from the Q wave and finish with the end of T wave. So that's your QT interval. So lastly, you will comment on the QT interval as well. So that's how we usually talk about the ECG in exam. So in a sense, if you look at here, this is exactly the SVT ECG. In SVT, you will have no P wave. There will be narrow QRS complex, and that's only the finding that you will be looking for. Obviously, rhythm will be regular and rate will be increased. When we explain ECG to an examiner, we follow this approach. So we say to the examiner that, dear examiner, I would like to describe the 12-lead ECG of my patient, John, who is a 25-year-old gentleman, came to me with a sudden onset palpitation and giddiness. Can I please confirm that this ECG is Mr. John's ECG? Because we always confirm that the ECG is the patient's ECG. Then, yes, examiner say, yes, this is the patient's ECG. So the ECG shows heart rate 150. So whatever you find here, if you find 300, you will say 300. So heart rate 300 beat per minute, regular in rhythm, absent of P wave, narrow QRS complex, no ST wave changes, T wave normal in size and shape, and QT interval is normal as well. So this is the format that you have to use when you explain ECG to the examiner. So see the first P wave, then QRS complex, then ST wave, then T wave, and lastly QT interval. So that's the format that you use for any ECG explanation to the examiner. Okay, any question, guys, with this one? There is no need to comment on excess and hypertrophy. If you know it very well, then yes, you can comment on it, but it's not mandatory to comment. All right, so that's about this ECG explanation to the examiner. So how we explain this to the patient? So you have to explain the diagnosis. So say that, thank you so much, John, for your patience. So according to the history and physical examination, you have most likely you have a condition called supraventricular tachycardia. Let me discuss it in detail. So remember when the nurse put some leads on your chest, that is what we call as electrocardiogram of your heart, which means that this ECG can record the electrical activity that's conducted in your heart. So let me draw a picture for your better understanding. So this is your heart. Electrical impulse originates from here, and then it goes all over the heart to pump the blood to your whole body. In your case, there is some abnormality in these electrical impulses, especially the impulse that comes from the top part of your heart, which causes your heart to beat faster than normal. And that's the reason why you are having this thumping of your heart. And because your heart is beating faster, it is not getting enough time to fill in. And as it is not filling in, your body, especially your brain, is not getting enough blood supply. And that's the reason why you feel giddiness or lightheadedness at the moment. This is exactly what we call as supraventricular tachycardia. Do you understand me so far, John? Is there any question? No, doctor. Now, there could be many reasons behind it. Like it could be due to some structural heart problem, can have problem with your valve, which is the door-like structures which allows blood flow throughout your heart. It could be related with some medications, recreational drug intake, excessive tea, coffee intake, thyroid dysfunction, sometimes even due to some infection in your body. Okay, so just give some of the reasons why supraventricular tachycardia can happen. Especially, supraventricular tachycardia can happen in a young, healthy individual as well, without any underlying heart problem. So you can always say that, please don't get stressed about it. Sometimes a young, healthy patient also can get this kind of rhythm disorders. So please don't get worried about it. We will do a full investigations for you to find out why you are having it. Now, I have never seen management coming in exam for SVT, but if you really need to know, then any of these patients, you need to send them to the hospital for further management. Sometimes you can try some conservative approach if patient is vitally stable. So vitally stable patient, you can start with some vagal maneuver. Sometimes you can try the Valsalva maneuver. You can also try immersion of your face in a cold water. You can try the carotid sinus massage. So any of these three is fine. If conservative approach doesn't resolve the problem, the next thing is medication, which is the IV adenosine. If IV adenosine is not available, then you can try some rate-limiting calcium channel blocker like verapamil. Even after that, if patient is not resolving, the last option would be DC cardioversion. If a patient is unstable, first option is DC cardioversion. So that's actually the management of supraventricular tachycardia. As I say that it doesn't come in exam, so please don't bother too much with it. We consider a patient stable in this arrhythmia that if their blood pressure is normal, that means not less than 90/60, patient mental status is fine, patient not complaining severe dyspnea or chest pain. So basically, a patient with arrhythmia called unstable, if they are in a shock, like blood pressure less than 90/60, if they are having confusion or altered mental status, or if they are having acute severe symptoms, especially chest pain, dyspnea, those kind of things. Okay. So that's your supraventricular tachycardia. As I said in previous class, that you don't need to explain too much about this. You just touch the point so that patient understand what it is. You don't need to explain ECG to the patient. You don't need to explain supraventricular means that there are atrium, there are ventricle, then obviously supraventricular means it's coming from above your ventricle. You don't need to do that, because patient doesn't care about it. You just need to discuss in a simple way so that they understand what they have got. It's more important to correlate the patient's symptom with their condition rather than explaining the pathophysiology of the condition. Okay. Next is atrial fibrillation. You have got a middle-aged lady comes to the ED with sudden onset palpitation. Task is to take a history, physical exam, investigation from examiner, explain causes and complication of the condition. So that's a new task. Now the positive points in the history will be totally same like we have done. So patient will come to you with a feeling palpitation or racing of the heart, sometimes giddiness, and they might also have it before as well. So same thing, history is totally same. Physical examination, totally same. Then your third task would be ask investigation from examiner and explain investigation to the examiner. So you ask about ECG and you will get this kind of ECG from the examiner. So again, you will look at the lead 2 first. In the lead 2, you can already see that RR interval is not regular in here, right? So there is obviously an irregular heart rate. If you get an irregular heart rhythm, you immediately think that it is most likely atrial fibrillation. And then you can find out that you can't see any P wave in here. The P wave in atrial fibrillation will be replaced by some fibrillatory wave, like this, like a wave. When it gets replaced by a sawtooth appearance wave like this, that is atrial flutter. But when it is replaced by some wave-like structure, like a wave, something like this, that is the fibrillatory wave that you get in atrial fibrillation. Okay? Also, in atrial flutter, you can get regular rhythm. Sometimes you can even get irregular rhythm in atrial flutter. So, what you are going to explain in here. So, your ECG explanation, introduction will be same, and you will again say what is the heart rate. Now, the problem is when you get an irregular heart rate like this, you can't measure the heart rate because it is very difficult to measure it by the time that you have given in the exam. So if it is an atrial fibrillation, don't bother too much with the heart rate. Even if you don't say that what is exactly the heart rate is, examiner doesn't bother with that. So you can only say that heart rate is elevated or heart rate is increased. Then obviously rhythm is irregular. Absent P wave, which is replaced by fibrillatory F wave. You can also get some narrow QRS complex. No ST wave changes. T wave normal, QT interval normal. So that's the ECG finding that you usually get in an atrial fibrillation patient. Okay. Now remember I told that sometimes atrial flutter also comes in exam. In atrial flutter, two kind of thing can happen. One, that you can get a sawtooth appearance. So if you see here, you will find out that 1, 2, 3, 4. And then after 4 P wave, there is 1 QRS complex. Same in here, 4 P wave, 1 QRS complex. Same in here, 4 P wave, 1 QRS complex. So this is called 4:1 block. If a patient has got 4:1, obviously the rhythm will be regular because everywhere patient has got same block. Okay, so that's what you get in atrial flutter. But sometimes in atrial flutter patient, the rhythm can be irregular if this block is not constant. So let's say if 1, 2, 3, 4, 1 QRS complex, then 1, 2, 1 QRS complex, then 1, 2, 3, 4, 5, 6, 1 QRS complex. Now you can see that this doesn't look regular anymore because it has got 4:1 block, now 2:1, 6:1. So obviously this is also atrial flutter, but having an irregular rhythm. So always remember, just because you have got irregular rhythm in ECG, it doesn't mean that it has to be atrial fibrillation always. It can be atrial flutter also. The important thing that you look at is what is the wave? Does the wave looks like a sawtooth like this, or does the wave looks like a wavy pattern? So if it's like a wave, that's atrial fibrillation. If it's a sawtooth appearance, that's atrial flutter. Okay. In atrial flutter, rhythm can be regular or irregular. If in case of atrial fibrillation, it will always be irregular. So your explanation. So the good thing is that atrial fibrillation and SVT explanation is same. Only thing which is different is your diagnosis. Because you're explaining the same thing, right? If you go to our SVT explanation, you can see that you will start with that when the nurse put the lids on your chest, we have done your ECG, which means that it's an electrical record of your heart. Then we draw the picture, show the same thing, that this is your heart, electrical impulse originate from here and then goes all over the heart to pump blood to your body. In your case, there is some abnormality in these electrical impulses, causing your heart to beat faster than normal, and also it's beating in a chaotic rhythm. That's the only thing that you can add, that faster and chaotic. That's why you are having racing of your heart, and as your heart is beating faster, it's not getting enough time to fill in, your brain is not getting enough blood, that's why you're getting the giddiness. See, it's exactly the same explanation, okay? Then you can explain that what could be the causes of atrial fibrillation, because that's one of your tasks. Now, causes of atrial fibrillations might be a lot of things. The important ones are high blood pressure, history of heart attack or coronary artery disease, abnormal heart valves, congenital heart defect, thyroid disorder, excess stimulant such as excess coffee, smoking, alcohol, history of lung condition, previous heart surgery, viral infection, and stress. And sometimes in even 25% cases, there might not be any causes, which we call lone AF. Okay, so these are the causes of atrial fibrillation that you can talk about. The other task is discuss the complications of AF. So there are mainly two important complications of atrial fibrillation. One is a stroke and heart failure. So in atrial fibrillation, the chaotic rhythm may cause the blood to pool in your heart's upper chamber and form clots. If a blood clot forms, sometimes it can dislodge from your heart and it can travel to your brain and block the blood flow to your brain, causing a stroke. It can also cause another condition called heart failure. Left untreated, it can weaken your heart muscle, and then your heart muscle will not be able to pump enough blood to your body, and that is what we call as heart failure. So these are the two complications of AF. AF management I have not seen to come in exam, but if you want to know, then any of this AF patient usually goes to hospital if it is the first diagnosis. Again, if the patient is stable, then your management depends on rate control and rhythm control. So usually you start with rate control if patient having a increased heart rate, which we call atrial fibrillation with rapid ventricular response. Okay, so if a patient with AF has got tachycardia, that what we call as AF with rapid ventricular response, RVR. So in that case, your first thing is to control the rate. How you control the rate? You can either give beta blocker, which is atenolol, metoprolol, any of those, or rate limiting calcium channel blocker, like verapamil, diltiazem. If rate control doesn't work, then you can try the rhythm control. Rhythm control are anti-arrhythmic medication. Commonly used are sotalol, flecainate, and amiodarone. So those medications are usually the rhythm control medications for AF. If a patient is not stable, or if rate rhythm control does not resolve the AF, then your last option would be DC cardioversion, which means a shock. Is there any curative treatment for AF? Yes. If a patient has got permanent AF or recurrent AF, which causing symptom or even affecting the heart, that patient sometimes might be eligible for a curative management called catheter ablation. In catheter ablation, they use some radio frequency wave to destroy these chaotic rhythmic origins. And in that way, the atrial fibrillation patient will be totally fine and cured. But it's a complicated medication, complicated management, so not everyone gets it. Okay, so that's actually the management of AF. AF management will never be finished without a prevention of a stroke or embolism. So you have to use some scoring called Chats-Vusk score. And according to that score, if Chats-Vusk score is 0, then you don't need to give them any anticoagulant. If Chats-Vusk more than equal to 1 or 2, so if it is more than 2, obviously you have to give it. So either warfarin or newer oral anticoagulant. Nowadays, newer oral anticoagulants are more preferred than warfarin. Okay. If a patient has got a valvular heart disease and AF, that's the absolute indication for warfarin. If a patient has got non-valvular AF, then you can give the newer anticoagulants like any of the apixaban, rivaroxaban, or dabigatran. Okay, so that's actually the management of AF. As I said that it doesn't come in exam. I've seen maybe once, so have some idea only. That should be enough for it. Is this clear, guys? So look at the Chats-Vusk score, that how to do that scoring, because in exam you will not be able to do all of it. You have to think that if a patient has got, like if the patient age is more than 75, if a patient has got prior history of TIA or a stroke, if a patient is hypertensive, diabetic, okay, those are actually the sign that this patient will need some kind of anticoagulant. All right, so that's actually all about the palpitation cluster. These two are usually the important one that comes. We already did a prolonged QT syndrome in our previous class, so that should be more than enough. Okay. Now moving on to chest pain cluster. That's one of the most important cluster for cardiovascular system. So for chest pain cluster, again, we will start with some of the differential diagnosis. And chest pain has got a lot of differentials. So start with the CVS. In cardiovascular system, chest pain, it can be just a stable or unstable angina, can be myocardial infarction, can be pericarditis. It is very commonly asked, these two, MI and pericarditis. Can be aortic dissection, aortic stenosis. So those are the CVS causes of chest pain. Then we have some respiratory causes like pneumonia, pneumothorax, pulmonary embolism. GIT causes, reflux, peptic ulcer disease. Those are the usual causes. Musculoskeletal, costochondritis or TJ syndrome, and rib fracture. Neurological, either it's a thoracic or cervical prolapsed disc or herpes zoster. Then some psychological causes, especially anxiety related or panic attack, that can be the cause of chest pain also. So chest pain actually has got a lot of DD. And if in the exam, they ask that a patient coming to you with a chest pain, take history for 6 minutes and give you a diagnosis and DD, that means they are actually expecting that you will ask all these differential diagnoses. So the history is very important in a patient with chest pain. And we have to be a little different in approach in here. Now, if you have got a patient who is middle-aged or elderly, like above 40, and coming to you with a chest pain, you should always consider the possibility of a heart attack or myocardial infarction. Okay? So in that case, what you usually do, you start your history, make sure you offer some painkiller and make sure patient is hemodynamically stable. Now, this painkiller thing, we haven't came approach before. In your clinical exam, if you see in the stem that patient having pain, it is must that you have to offer them some painkiller initially, even before starting your history. So these two are must. If a patient having pain, you offer painkiller. If a patient having some acute presentation, you make sure patient is vitally stable. So in the history, first of all, you will start again the same approach. So greet the patient, reassure the patient that you are here now. We are going to take care of you. So please don't worry. So let's say in this case, the best approach, I would show you here, just a second. In a patient who has got chest pain, and if it is a middle-aged or elderly patient, your starting should be like this. So, hi, John. This is Dr. Asha, one of the doctor here. It's very nice to meet you. I got to know from the notes that you are having chest pain. I'm very sorry to hear that, John, but please don't worry. Now that you are here, we are going to manage your symptom and we are going to find out the cause of your chest pain. Now, would you please tell me how severe your pain in a scale of 1 to 10? Doctor, it's 8 by 10. I'm very sorry to hear that. It should be very stressful for you. I'm going to arrange some painkiller for you right now. Do you have any allergy to any medication? No, doctor. Well, that's fine then. I'm going to arrange some painkiller. Hopefully you will feel comfortable after that. Now you just say painkiller. You don't need to say the name or dose of the medication. Okay, so first thing that you ask that, I'm sorry that you are having a chest pain, but now that you are here, we are going to take care of you. Will you please tell me how severe is your pain in a scale of 1 to 10? Doctor, it's 8 by 10. Do you have any allergy to painkiller? No, doctor. Well, I'm going to arrange a painkiller for you. Hopefully, you will feel comfortable after that. Now, because you are having chest pain, I would like to make sure that you are stable enough to answer my questions. So please excuse me for a moment. I will come back in a moment, or I will come back. I'm going to talk to my examiner. I will come back to you soon. So dear examiner, I would like to know if my patient vitally stable for further history. Examiner says yes. Now, even after patient is vitally stable, if a patient has got, like in your stem, if a patient age is more than 40, and along with that patient is a smoker, had history of hypertension, diabetes, dyslipidemia, that means increased cardiovascular risk. If you have got a patient like that, then you should say, because of increased cardiovascular risk in my patient, I would like to take my patient to the resuscitation cubicle, ask my nurse to hook a ECG monitor with the patient's bed. I will make sure that he gets continuous observation during this time. I will also insert 2 large bore IV cannula, and I will take some blood, especially for cardiac enzymes, and offer the patient some painkiller immediately. So that's your first thing that you do. Always remember, it's not mandatory for a 26-year-old having a chest pain to do this step. But as I say, that if you have got a patient who seems to be in a high risk of cardiovascular issue, then yes, initially we have to take this patient to a resuscitation cubicle or resuscitation room. In every hospital ED, usually they have a resuscitation room. Okay, so you just say that you want to take that patient to the resuscitation room. hook ECG monitor or attach ECG monitor to that patient, and insert 2 large bore IV cannula, take blood, especially for cardiac engine, and offer the patient some strong painkiller. So that's the theory in this patient. Now, are we going to give them monotherapy at the moment? It's not must, because most of the time in MI cases, management is a task. So in that case, during management, you can talk about monotherapy like morphine, aspirin, nitroglycerin, and oxygen. But you don't need to do it at the moment initially, unless you have got a ECG in your question and you already know that the patient has got an acute MI. Okay, does that make sense, guys? Like, I know that this is a little new for you, but do you understand what I am saying? No, Dr. Abdul Bari, you should never ever ask hemodynamic stability from the examiner first before starting with the patient. If you do that, you will fail the case. You should always introduce with your patient first, and then excuse from them, and then go back to the examiner. Okay, good. So we make sure that patient now has got some painkiller. We made sure patient vital is stable. Even though patient is stable, we would take the patient to the resuscitation room, attach ECG monitor, take the blood, especially for cardiac enzymes. And then once you have done that, you come back to the patient and say that, thank you so much for waiting, John. Now, would you please tell me a little bit more about your chest pain? So patient will already give you a lot of information, but you need to make sure that you get the pain questions all correct. So any pain, we always use Socrates. And Socrates means what is the site of the pain? So where exactly is the pain? Onset. What exactly were you doing when the pain started? And that means, did it start suddenly or gradually? Character. How does the pain feel like? Any radiation? Any associated symptom? Duration of the pain. That means how long or when did it start? Any exacerbating or relieving factor? And what is the severity of pain? We already asked about it, right? Severity in initial questions. So this Socrates is the pain assessment for any pain, headache, chest pain, abdominal pain, any pain. This is the question. So we want to know that when did it start? What exactly were you doing at that time? Did it start suddenly or gradually? Is it for the first time? Is it continuous or on and off? Where exactly is the pain? Does the pain travel anywhere? Now, you can't ask the patient that, does the pain radiate anywhere? You'll get questions back from them. What is radiation, doctor? And then you have to explain what is a radiating pain. So don't ever use medical jargon. So does the pain travel or go to anywhere? Can you describe how the pain feels like? Now, this is a very important question for chest pain. If chest pain feels like constricting, heaviness, squeezing, that suggests heart or cardiac pain or ischemia pain. If it is a burning pain, that might suggest reflux problem or peptic ulcer disease. If it is a stabbing, knife-like pain, that suggests pericarditis. So the character of the pain is very important. It gives you diagnosis sometimes. Then ask about anything makes it better, anything makes it worse, like breathing, coughing, or doing any exertion. Obviously, chest pain will get worse with exertion if it is a ischemic chest pain. Chest pain will get worse with breathing and coughing if it is a pleuritic kind of pain. Like a patient with pericarditis will get worsening of their chest pain with coughing, breathing. Same patient with pneumonia, pulmonary embolism, pneumothorax, all pleuritic pain that get worse with taking deep breath or coughing. So that is also important that you can directly ask that anything makes it worse, like breathing, coughing, or doing any exertion. So that's your chest pain question. After that, ask that along with the chest pain, have you got any difficulty in breathing, any racing of your heart, any nausea, vomiting, excessive sweating? So all of these are serious symptoms, right? So you have serious, differential, and all of this, especially MI patient, will have shortness of breath, nausea, sometimes even vomiting, and excessive sweating. So those are the questions for ischemic heart disease or MI, and racing of heart to rule out any arrhythmia. Then you move on to some of the other differential diagnoses. So we have pericarditis and aortic stenosis. So for pericarditis, does the pain get worse when you lie down? And does it get relief when you lean forward? So patient with pericarditis, their pain, usually retroesternal chest pain, feels like a stabbing pain or a knife-like pain. And the pain usually get worse with coughing or deep breathing, and also when they lie down. But they usually get better when they lean forward. So sometimes in the question, if it is a pericarditis patient, you will find out that when they're sitting in front of you, they're sitting as if they're leaning forward. So that is actually like they are trying to help you to show that I'm actually leaning forward. That means that's pericarditis patient. Okay. And also most of the time they have a recent viral flu-like illness. So always ask that, have you had any recent flu-like illness? So that's pericarditis questions. For aortic stenosis, any dizziness or sudden blackout? We already asked other questions like chest pain, shortness of breath. Aortic dissection does not have any specific question. It's the character of the pain which will give you the diagnosis. Aortic dissection also comes very suddenly. So it's a sudden onset, severe chest pain, usually retroesternal, but that radiates to the back. So if the chest pain radiates to the back, then you have to think about that it is most likely aortic dissection. So after that, we have lung causes. So for pneumonia, any fever, any cough, any difficulty breathing. So you already asked difficulty breathing, so no need to ask here again. So any fever or cough for pneumonia. For pneumothorax, any trauma to your chest. Again, all the symptom questions for pneumothorax already been asked, like shortness of breath, chest pain, we already asked it. Only question that is remaining is trauma to the chest. You can also ask that any underlying lung condition that you have got. For pulmonary embolism, any recent travel to anywhere, any personal or family history of clot formation in your legs or lungs. Pulmonary embolism has got a lot of questions here to ask, but you don't have that much time to ask all those questions. At least ask that any recent travel history and any previous or family history of clotting disorders. For reflux, does the pain has any relationship with food? Any heartburn or any bitter taste in your mouth? Okay, so for reflux, we are going to ask this question that does the pain has any relationship with the food, any heartburn or any bitter taste in your mouth? After that, we have musculoskeletal, that's costochondritis or rib fracture. So for costochondritis, one question is enough. Does your chest feel sore to touch? Or is the chest sore to touch? Patient with costochondritis, the costal cartilage gets inflamed, and when they touch their chest, it is very tender. So that's the only condition of the chest which is sore to touch. Then for neurological, only one question, herpes zoster. So have you got any rash on your chest? Then for psychiatric causes, especially anxiety related, give some confidentiality statement, and then ask that, who do you live with at home? Is there any stress going on at your home or work? Are you generally an anxious person? Okay, so those kind of questions you will be asking. Lastly, finish with SADMA. So do you smoke or drink alcohol or any other recreational drugs? Ask about, already we asked stress. Ask about past medical history, family history, and medication history. In past medical history, ask directly any history of diabetes, high blood pressure, high cholesterol, or any heart condition, any family history of heart condition, and are you on any regular medication? All right. So that's actually the history that you have to ask in chest pain. As you can see, there is a lot to ask, right? But most of the time, you will not need that much questionnaire because the task will be like maybe 2 tasks only in the exam. So depending on how many tasks that you get, your differential diagnosis should be smaller. You don't need to ask all the questions. Remember it. It always depends on the number of tasks that you have got in the exam. If you have got 4 tasks, you don't need to go through all these questions. So you just need to cut it short at that time. Any question, guys, with the history? So if I give you the summary of chest pain cluster, then in the history, make sure first introduce yourself, reassure the patient, offer painkiller, make sure patient vital is stable. If high risk of CVD, then take the patient to the resuscitation room and manage accordingly. After that, you start your history. First, pain question, followed by associated questions of MI. Then you go for other heart condition like pericarditis, aortic stenosis. Then you have got 3 questions for respiratory condition, 1 for your GIT, which is the reflux, then for musculoskeletal costochondritis, neurological heartbeat zoster, and lastly, psychological. And finish with SADMA, past medical history, family history. Okay. So do we need to name the differential? No, Dr. Amit, you don't need to do that. It's just for your understanding. Yes, Dr. Priyanka, if a patient, like any patient who is having chest pain, which is acute onset, you have to ask the PE question. That's always a possibility, especially if a female patient taking OCP, that can be one of the risk factor of having a PE. You can ask in that way, Dr. Amit, but it doesn't make it sound good, because when you ask directly this question, it shows to the examiner that you know that what you're looking for. Okay, that means you know the risk factor of a MI. All right. All good. So then you go to the physical examination, which is same like before. So just make sure that if you think that this is a pericarditis patient, then don't forget to ask about any pericardial rub on auscultation, because you can get a pericardial rub in a pericarditis patient. Other than that, others are all same. Any question? Now, what we will do, let's just take a little break before we start the chest pain discussion. So we'll take a 5-minute break and then we will start with the pericarditis and acute MI. Okay? So 5-minute break, guys. right, everyone, let's start again. Starting with pericarditis. So you have got a 50-year-old tram driver presents with a sudden onset chest pain since 2 hours. Now, when you get a 50-year-old having a sudden onset chest pain, you don't think about pericarditis as your first diagnosis. You always think that it is most likely a MI unless proven otherwise. Okay, so your tasks are similar. The positive points in this case that patient has got a chest pain for 2 hours, aggravated by lying down and deep breathing, relieved by leaning forward. So this will give you a diagnosis. The character of the pain is a stabbing in nature. It also radiates to the back, and patient also gives a history of flu-like illness. So everything goes with pericarditis. And then when you ask for ECG from examiner, this one pops up. Now, understanding the ECG of pericarditis and MI, it is very important because it can be quite confusing in the exam. In a basic way, pericarditis ECG shows widespread ST elevation in almost all lead of the ECG. So you get a ST elevation, and the ST elevation is a concavity upwards like this, as if it's a chair where you can sit like this. Okay, so see this one, like you can sit over here and then relax. So the pericarditis ST elevation looks like this, like a concavity upwards. So what happens? First thing first, you need to first understand what is ST elevation. To understand ST elevation, first thing you need to understand is that what is the baseline or isoelectric line of an ECG. The isoelectric line is the line that you can see all over. So this is the isoelectric line or the baseline. In the baseline, your ST wave also should be here. So in a normal ECG, your ST segment should come here, and then there should be T wave like this. So when the ST segment goes upward from this isoelectric line, that is what you call as ST elevation. Okay, now when you have got a patient with chest pain, your first thing that you look at is the chest lead. So V1 to V6. So in the V1, I can't see any ST wave elevation. In V2, if you look at here, there is a little bit of ST elevation, but obviously in V3, there is ST elevation, V4, V5, V6, all of it having ST elevation. And most importantly, this concavity upward kind of ST elevation. Once you have done that, then with anterior leads or in the chest lead, normally if you have got a patient with myocardial infarction, then this is called anterior leads, this V1 to V6. Then there are some high lateral leads. The high lateral leads are lead 1 and lead AVL. So you look at lead 1 and AVL after that, because sometimes anterolateral MI can be there. So that's why you look at lead 1 and AVL after looking at V1 to V6. So in lead 1, also there is ST elevation. Lead AVL, there is a little bit of ST elevation, not too much, but still there is some. Then there are inferior leads. Your inferior lead is lead 2, lead 3, and lead AVF. If it was MI, if you have got ST elevation in anterolateral lead, anterolateral means V1 to V6 is anterior, lead 1 and AVL is lateral. So if you have got ST elevation in anterolateral lead, if it was a MI patient, you should get a reciprocal ST depression in inferior lead. That means if it was actually MI, you should get ST depression in lead 2-3 AVF. But if you look at here, in lead 2, there is ST elevation. That doesn't go with MI ECG. Lead 3 and AVF, not too much changes. But again, as you have got ST elevation in lead 2, it is not MI. In MI patient, if you get ST elevation in anterolateral lead, you should get ST depression or even a flat ST wave in lead 2-3 AVF or inferior lead. So that's how usually you can easily find out in the exam that is it a MI patient or pericarditis patient. And also this concavity upward kind of ST elevation that also helps you in the exam. Okay, so that's your ECG for acute pericarditis. Any problem with understanding this one, guys? Great. So then you can explain that according to the history and physical examination, most likely you have got a condition called acute pericarditis. Do you know what it is? No, doctor. So let me explain. So acute pericarditis, it's a condition where there is inflammation of the outer layer of your heart called pericardium. Let me draw a picture for your understanding. So if this is your heart has got an external covering, which we call pericardium. In your case, most likely this has got inflamed. And I'm suspecting that because you had a recent viral infection, this inflammation is just a reaction to that viral infection. As the covering of your heart has got inflamed, that's the reason you are getting a stabbing kind of chest pain, which gets worse when you lie down, and it gets better when you lean forward. Now, it could be due to other reason as well. Like, obviously, I was thinking it could be a heart attack, but your symptoms, your ECG does not go with heart attack. It could be due to aortic stenosis, then give the lung differential, all the differential diagnoses that you asked, you can say one by one. So say that please don't worry, most likely it is not a heart attack, but to confirm my diagnosis and to exclude chance of heart attack, I would like to keep you under observation in hospital. I will also call my senior and also the heart specialist who might want to do further investigation, especially full blood examination, inflammatory marker, kidney function, a repeat ECG, troponin, and also an echocardiogram to confirm the diagnosis. If it is confirmed to be pericarditis, then there is nothing to worry about. You will be able to go home and you just need to take bed rest and some painkillers for your pain relief. We always finish with 4R. So what is 4R? If you are discharging a patient from your GP setting or hospital setting, your finishing should include 4R. 4R means review. So when you want to review the patient again, do you want to refer this patient to somewhere else? What are the red flags patient needs to know about that suggest it is a severe problem, and offer them some reading materials? So let's say for this patient, it's in the hospital. If you want to discharge the patient, you would say that if you are going to be discharged, then I would like to write a letter to your GP who would follow you up once you are discharged from hospital. So because it's the emergency department, you are not going to review the patient again. So you can write a letter to his GP who can review the patient. So that's your referral. If any time you get a chest pain, which is very severe, left-sided, and also it persists for a long time, and you get kind of heaviness in your chest, and the pain goes to your left arm, neck, or jaw, please call ambulance and come back to the emergency department immediately. I'll give you some reading material about acute pericarditis so that you understand your condition much better. Do you have any condition? Do you have any question? All right, so that's called 4R, especially if you are discharging a patient from hospital. If you are sending a patient home from your GP setting, we always use 4R at the end. All right, so that's how we are going to finish this pericarditis. Now come to the most important out of everything that we have done in cardiology, which is the acute MI. It comes in exam so frequently that like you can't even imagine. So a 55-year-old man comes to your ED with a sudden onset crushing chest pain. So same history, physical exam, investigation from examiner, likely cause of the pain and immediate management. This is one kind of question. There is one other question in which in the stem, they would they will give you the ECG and you will know that that patient has already got MI. In that case, the history should be just very short history, not about all the differential diagnosis. Okay? But when they don't give you the ECG, then you have to ask a couple of other differential diagnoses as well. So positive points in here was acute onset of severe chest pain, which was crushing in nature, radiating to jaw, neck, left arm, and it is the first time patient has got it. So you know that acute MI pain comes usually sudden onset, so left-sided or retrosternal chest pain, which feels like heaviness, squeezing, constricting, or crushing in nature, severe in intensity, and usually radiates to the left arm, neck, and jaw. Along with that, patient also got shortness of breath, nausea, vomiting, and sweating. History of smoking was positive, no other history of heart condition. So in this case, again, that when you start, before starting the history, the same thing. You reassure the patient, offer painkiller, ask the stability, take the patient to the resuscitation room. Those things, you have to do it. So that's what we have written in here, that I would like to take my patient to the resuscitation cubicle, attach him on cardiac monitor, ask my nurse to do an ECG, will secure an IV line, take blood for cardiac enzymes, and also start the patient on oxygen if saturation less than 94. We don't start oxygen to all patients, only if saturation less than 94, then we can start the oxygen. Okay? Now, if in your stem already there was a ECG given, which was MI ECG, in that case, along with everything that's written in here, you will also add that you would like to start this patient on 300 milligram of aspirin. Okay, and also nitroglycerin. But as long as you talk about aspirin, you are fine, because nitroglycerin is not always. If morphine doesn't make the pain, like if patient doesn't feel better with morphine, then again, nitroglycerin can also relieve the chest pain. So then we give the nitroglycerin. Oxygen only needed if saturation less than 94. But aspirin is for everyone. Okay? So after you have done that, then you finish your whole history, physical examination. You ask ECG as your investigation, and examiner give you this ECG. Let's say that this is the ECG that you have got. When you get a patient with chest pain and you get a ECG, obviously you look at V1 to V6 first, and you look for ST elevation. So in the V1, you can see that there is no elevation. In V2, so that's your isoelectric line, and that's your ST wave. Okay, so obviously ST elevation is there, right? You can see here more. This is called J point. So see that it is not a concavity upward like that. In case of pericarditis, you get just like this kind of ST wave. But in MI, the ST wave is little different. So obviously this one is having a ST elevation. In V4, this is your ST elevation. V5, also ST elevation. V6, also ST elevation. So there is widespread ST elevation. Then you look at lead 1 and AVL. Lead 1 has got ST elevation. Lead AVL has got ST elevation. Then you look at lead 2, 3 AVL. See that lead 2, 3 AVL, no ST elevation. That means that's fine. That is a MI patient. Okay, and the condition will be anterolateral MI, because if V1 to V6 there is ST elevation, that's anterior MI. When you also get ST elevation in lead 1 and AVL, that's lateral. So together it will be anterolateral MI. Okay. Usually in these cases, they will not give you any long leads, because long leads doesn't matter in here. All that matters is all these leads. Now tell me here, guys, that what you can see in this ECG. So we start with the V1. So V1, there is ST elevation, right? Obviously V2 has got ST elevation, V3 ST elevation, V4 ST elevation, V5, V6, not very much. Look at lead 1 and AVL, ST elevation, ST elevation. Lead 2, 3 AVF, fine. So that's again anterolateral AMI. Okay, so that's some of the ECG that you will require for your exam. Apart from this ECG discussion, you don't need anything else. So in terms of management, they're asking for an immediate management. So not like a full management of AMI, not a long-term management. So immediate management. So thank you so much, John, for waiting. So based on the nature of your chest pain and according to the ECG, I am afraid that most likely you are having a condition called acute myocardial infarction or heart attack. John, I'm very sorry. I wish I could give you some good news. I need you to understand that this is a very serious condition. In this condition, the blood pipes that supplies your heart can get blocked by some clot, and as a result of that, your heart muscle doesn't get enough blood and oxygen. And the part of your heart which doesn't get blood, it can be totally non-viable, and it can lead to serious complication. But please don't worry, you are in safe hand. And it is very good that you came early, and with proper intervention, this can be managed very effectively without these serious complications. But I need to act on this as soon as possible. I'm going to admit you to the hospital, call the cardiologist who will come and review you immediately. In the meantime, I'm going to give you a tablet called aspirin. which you need to chew only, and that can also prevent further clot formation. I have already given you a strong painkiller called morphine, and we'll continue giving you more until you feel comfortable. If your oxygen saturation goes down, we will also start you with oxygen. If you have ongoing chest pain, even after giving morphine, we will give you another medication called nitroglycerin, which can relax your heart arteries and promote more blood supply. Are you with me so far, John? You're understanding what I am saying? Yes, doctor. The specialist might do further investigation, including all these basic blood tests, full blood count, inflammatory marker, your liver kidney function, your blood sugar level and lipid profile, and also a cardiac enzyme. John, the definitive treatment of this condition is to remove the clot and restore the blood flow, what we call as percutaneous coronary intervention or thrombolysis. This will be decided by your specialist based on the duration and severity of your condition. Now, if you have got some time, you can explain what is percutaneous coronary intervention and what is thrombolysis. The percutaneous coronary intervention, in this procedure, a small flexible wire will be passed into your heart arteries, looking for the exact site of the block and the severity of the block. And if needed, the specialist will put on a balloon on that artery to open up that artery to restore blood flow. In case this is not possible or your duration of symptoms is more than what is needed for a PCI, then a specialist might give another form of clot dissolving medication, and that can also help you to restore the blood flow in your heart muscle. All this will be decided by the specialist based on your duration and severity of the condition. I understand that it is very shocking for you, John. And I know that you were not expecting this when you came here today. But as I said, that if you were not here early, this could lead to very severe life-threatening complication. But now that you are here, still we have a lot of time to make sure that your heart becomes completely fine like before. But if you need to call your friends, family members, please let us know. We'll be more than happy to call them, and then they can also come and visit you. If you have any questions about anything, I will be here. Just call by my name and I will answer your questions at any point. Please don't worry. You will be in safe hand, and we have a very good team of cardiologists in this hospital. Okay, so that's very important. Actually, the last few lines that I've said is not in the note, but those are important. Okay, your examiner expects you to give this reassurance to the patient if it is appropriate. All right. Now, as your task was just immediate management, you don't need to talk about this. Like once you are discharged, then we'll start you with some medication, healthy lifestyle. Those are not important at the moment. So this part, don't say it right now. If immediate management is your task, you just finish as I have finished. Okay, because this patient will be in the hospital for a few days. Then you will talk about this. Any question, guys? So we start again from rhythm, rate, and all. Yes, Dr. Amit. Doctor, do we fail if we diagnose wrongly in stations with ECG? Yes, because that's your diagnosis. If you're wrong, the whole station is wrong. Yes, GP in clinic setting, they can take blood. That's fine. It's not for just exam purpose. So if needed, especially for severe cases, GP can also take the bloods. All good? So that's about this MI, which comes frequently in exam. And if you follow the approach that I have shown to you, you will be fine. No, you don't need to be that much precise on type of MI. If you at least can say it's a myocardial infarction, that's fine. Now we'll be very quick with some of the other questions, which is not so important for exam. So one of them is angina. So you are in a GP setting, a 62-year-old male who presented a few days ago with chest discomfort. ECG done at that time was normal. A stress test was done later on, showed ST segment change in anterolateral lead. Patient had chest tightness during the test. Patient is a smoker, no history of diabetes. Explain the stress test, short-term and long-term management. So obviously, if patient at rest, they usually don't have chest pain. But when they do exertion or exercise, they get chest pain. That's a stable angina. And also, if you do a ECG at rest, that will be normal. But if you do a stress ECG, you will get some ST segment changes. Either you get ST depression or T wave inversion. So if you get those kind of feature in the ECG in a stress test, that suggests most likely patient has got some reversible ischemia. What we call as stable angina. So explain to the patient what is the result. So like you introduce yourself and then say that, hi, John, this is Dr. Ashan. It's very nice to meet you. I understand that for the last few days, you had some chest discomfort. How are you doing today? Are you still having this discomfort right now? No, doctor. Well, I understand that you are here to discuss about your stress test. Is that right? Yes, doctor. So how did that go? Did you have any discomfort during the stress test? Yes, doctor. I had some chest tightness during that time. All right. So I'm very sorry to hear that. It should be stressing for you. Now, John, I have got the result of your stress test. I'm going to discuss it in detail. If you don't understand at any point, please do not hesitate to ask me. So what actually happens, John, in a stress test that, first of all, when a patient has just chest discomfort during exercise, and we do a ECG at the bedside, and in your case, that was normal. But just to make sure that you don't have problem when you do exercise, that's why we order this stress test, in which you have to run on a treadmill, and then we will look for your symptom and any ECG changes. In your case, John, when we have done the stress test, we have found that your ECG has got some changes, and also you had chest tightness during that time. This is exactly what we call as angina. Do you know what it is? No, doctor. Well, angina is a name that is given to the chest pain or discomfort that comes from the heart when it is short of oxygen. The heart is supplied by some blood pipes, like everywhere in your body. And those blood pipes are known as coronary arteries. In this condition, these blood pipes get narrowed due to accumulation of some fatty substance. And as a result of that, when you do some exercise or exertion, your heart can't get enough oxygen. And that's the reason you experience chest discomfort or pain. Please don't worry, it is very common condition. Millions of people are suffering from this. But unfortunately, it can lead to serious complications like heart attack. That's why it is very important to follow a healthy lifestyle to prevent this complication. Are you with me so far, John? So every time, maybe in 1 or 2 minutes, just give a pause and ask the patient that if they are understanding you. Regarding further management, I will start you on some medication. First, aspirin, which helps to prevent any clot formation. Beta blocker, which is a medication to reduce your heart rate, but also it can help with the remodeling of your heart. Then also, I would give you a statin because of your high cholesterol. and another medication called nitroglycerin spray, which you need to just use it whenever you get chest pain. So you give one spray under your tongue when you get chest pain. So these are the 4 medications that I'm going to start you as an initial part of your management. Are you understanding me so far? Yes, doctor. If a patient has got hypertension, then also start the patient with ACE inhibitor, like perindopril or any of the ACE or ARBs. Okay, so that's usually the initial management. You give aspirin, you give beta blocker. If hypertensive, then ACE or ARBs, statin, and a GTN. Apart from medication, I also would recommend you to maintain a healthy lifestyle. So if you are drinking a heavy amount of alcohol, please cut it down to a standard limit. Try to maintain an ideal body weight. Please try to avoid smoking and always try to take a healthy, balanced diet. Please do some exercise, ideally 30 minutes of brisk walking on most of the days of the week, and try to avoid stressful work which can bring on the chest pain. In terms of further management, I will also refer you to a cardiologist as soon as possible for further management. Most likely, you are going to have an angiogram. In case of coronary angiogram, a dye will be inserted into your cardiac or coronary artery to find out exact location of your clot formation and also the severity of your clot formation. Based on the result of the angiogram, further step will be decided by your specialist. They might want to put a stent like a balloon to keep your arteries open, or they might also want to go for an open heart surgery if needed. Please don't worry about it right now because we have a long way to go. Let's start one by one. And obviously, your specialist will discuss this in detail. If you again have this kind of chest pain, please follow the angina action plan. So this action plan you have to say to the patient. If you have a severe pain, even after taking rest, take the GTN or nitroglycerin spray under your tongue and then wait for 5 minutes. If still you have got chest pain after 5 minutes, then notify a friend or relative that you have the pain. And then take another dose of the nitroglycerin spray and wait for another 5 minutes. Even after that, your chest pain is not relieved, call ambulance, take your 3rd dose and say that I'm having a heart attack. Okay, so patient usually can take 3 doses of nitroglycerin spray in 5 minutes apart. Even after that, still there is chest pain, patient should call the ambulance, say that I'm having a heart attack. And then obviously finish with 4R. So reading materials, review regularly. So that's about your angina action plan and like a management of angina. Any question? Next, angina due to anemia. This is another question. Now, this is a little tricky. This kind of patient will not come to you with a sudden onset of chest pain. They will come to you having a chest pain on and off for a long time. So 50-year-old man is in your GP clinic complaining of chest pain and dizziness for the last 1 month. See that it's been for a month. Now, someone having a chest pain for a month, this is not an acute condition. So you don't need to do any of the other things that we have done initially. You can reassure the patient, you can offer some painkiller, but no need of hemodynamic stability or taking the patient to the resuscitation cubicle. So you will take the history as we have done for chest pain. In this case, the positive points are patient has got a chest pain, which is on and off, 5 to 6 by 10 in intensity, constricting, retrosternal, comes and goes, precipitated by exercise, relieved by rest, and sometimes radiates. Patient also have some dizzy episode, usually feels very tired when standing from sitting or lying position. So maybe postural hypotension also. Smoker, alcoholic, cholesterol normal, diet healthy, no other surgical or medical condition, no family history of heart problem. In physical examination, you have got patient looks pale. That's the important finding. So that's pale in a patient means patient might have anemia, and anemia can cause chest pain also. So that is what we call as angina due to anemia. Blood pressure on sitting is 120/80, on standing 105/80. So there is obviously some postural hypotension, and all other findings are normal. But you have also done a DRE, and on DRE you have found blood. So this is one of the things. If you get pallor in a patient, so how a patient get pallor? And one of the things can be that patient might be losing blood in their stool, especially for a 50-year-old. So then you have to just do an abdominal examination followed by a DRE, and in the DRE you might get blood on your hand. So that suggests that it most likely patient is bleeding from the gut. That's causing the anemia, and that's causing angina. So see that like how the history folds. It is hard. Yes, like anything can cause anemia. So you just need to find out why this patient has got anemia. So you have to ask those questions. So let's say your history will start from chest pain question. Patient also have some DG episode. So dizziness also is one of the history. So you will ask the dizziness question. Can you tell me a little bit more about it? Do you get dizzy when you change your position? Any loss of consciousness? So a couple of questions you can ask about dizziness as well. Then associated symptoms are all the differential diagnosis of chest pain. But when you come to anemia, patient will say, yes, doctor, I feel very tired these days. Then you will think that, well, why the patient feels tired? So let's ask a little bit more anemia question. Then you have to ask that, do you take a healthy balanced diet? Are you a vegetarian? Have you got any change in your bowel motion? Have you noticed any blood or urine? Any loss of weight, loss of appetite? Any history of heartburn or indigestion? So those are the causes of anemia. So patient who are vegetarian can get iron deficiency. Patient who is bleeding from the gut or anywhere, they can get anemia. Patient with a bleeding peptic ulcer, that's why we are asking heartburn, indigestion, they can also get anemia. So that's the reason we are asking all these questions. Lastly, finish with past medical history, family history, and SATMA. So we are just adding the anemia questions in here. Physical examination is same, but in the pickle, you will get pallor. After doing CVS, you have to do the abdominal examination, and do not forget to do a DRE. And lastly, finish with the same office test. So your management will be from history and physical examination. Most likely, you have got a condition called angina due to anemia. Anemia means lack of blood in your body, which is most likely due to loss of blood from your back passes. And due to lack of blood supply, your heart is not getting enough blood and oxygen, causing this chest pain and discomfort, which you are having. And that is what we call as angina. Right now, I need to admit you to the hospital because you might need some fluids, because patient blood pressure was very low, especially the postural hypotension, and patient also losing some blood. So you can offer her some fluid as well. You will also be seen by a gut specialist and a heart specialist for further investigation and management. Further investigation might include full blood examination, inflammatory marker, a ECG, checking for your iron level, blood group and cross-matching, your liver and kidney function, blood sugar level, and cardiac enzymes. A specialist might also want to look into your gut and your stomach to look for any bleeding inside. So that might usually involve doing an endoscopy and colonoscopy. In this procedure, a flexible tube will be passed through your mouth into the stomach, and also one flexible tube through your back passage into your gut to look for any suspicious lesion or any bleeding inside your gut or stomach. Please don't get stressed about it. You will not even feel it because you will be on sleep or under anesthesia during that time. It will be totally painless. First of all, we need to stabilize your condition and find out the cause. And once the cause is found, you will be managed accordingly. Please don't worry. Now that you are here, we will try our best to find out the cause and manage it. Okay? So that's actually the management of angina due to anemia, because it depends on what cause that you have found in the history. If you have got a patient who is bleeding from the back passage, and that's a 50-year-old, you have to do endoscopy, colonoscopy for that patient. Okay? Any question? No, if anything is done on the stem, then we don't need to do it. So that's all about cardiology class tonight, guys. There is only one topic which I would not start tonight because that's a serious risk assessment. That's fine. What we will do that we will have a cardiology question solve class. And in the cardiology question solve class, we will do that serious risk assessment, and we'll just have a discussion of that particular topic and then have our cardiology questions or role play. Okay? So because already you have got 2 clusters for tonight, it will not reach into your head if we discuss the serious risk assessment today. So let's not confuse you anymore, but obviously that's for our serious role play session. We will start with that and then we will do some role play. Okay? Any question, guys? So now that you are actually at the finishing of our role play sessions, right? We have, I think, just 2 more class, one on cardiology role play, and then there is a pediatric cluster as well. So that's our free 2 weeks. I hope that you guys are enjoying the session so far. And obviously the course admission is going on at the moment. If you have any questions about the course, you can always ask it here, or you can email us or send me an inbox as well. So any of those are fine. All right, so that should be the class for tonight. And also, Dr. Amit, you will get a lot of chance of doing role play, because many of our students do they just go through the recordings. So in the online sessions, the amount of students that we usually get, that's enough for doing a role play. If you are active, you will have ample chance to do role play with us. And the procedure for installment, that if you enroll in our initial admission time, which is this month, then you have 2 installment, 1 half during this time, and after 2 months, half installment. Thank you, Dr. Lee. So that should be all for tonight, guys. I hope that you're enjoying. I hope that at least you're learning something. So that's all that matters. We'll see you in the next class. Have a good night.